A 72-year-old retired teacher named Margaret walked into her doctor's office for a routine checkup. She felt fine. Energy was good. She walked 3 miles every morning. Her diet was clean. She took her medications as prescribed. Her doctor smiled and said the words that would change everything. "Your numbers look great, but at your age, we should probably order a few more tests, just to be safe." 6 months later, Margaret was recovering from her third surgery, not because she was sick, because the tests found something. And that something led to more tests, more specialists, more interventions, each one designed to prevent a problem that might never have caused her a single symptom in her remaining years. This is called the cascade effect, and it's one of the most dangerous things that can happen to a person over 70. Not the disease, the testing itself. My name is Dr. Richard Harmon. I'm a cardiothoracic surgeon with 32 years in the operating room. I've opened over 2,000 chests. I've held beating hearts in my hands. And over the last decade, I've watched a disturbing pattern repeat itself. Healthy seniors walking into routine appointments and walking out with a medical trajectory that ends in harm they never needed to face. The tests I'm about to show you today are common. They're recommended by well-meaning physicians. They're covered by insurance. And in many cases, especially after 70, they set in motion a chain of events that does more damage than the condition they were looking for ever would have caused. Here's what nobody tells you. After 70, your body operates under fundamentally different rules. The margin for error narrows. Recovery from procedures takes longer. Complications that a 50-year-old walks away from can permanently alter the life of a 75-year-old. And the statistical risk-benefit equation that justifies these tests in younger populations flips completely. Your immune system isn't as responsive. Wound healing slows down. Your kidneys don't clear medications, and contrast dies as efficiently. Your heart doesn't bounce back from stress as quickly. These aren't failures. These are normal changes that come with 7 or 8 decades of life. But they fundamentally change how your body responds to medical intervention. And here's the part that matters most. The medical system wasn't built with this in mind. Guidelines are written based on studies of mixed-age populations. Recommendations are standardized. The same screening protocols that make sense at 50 are applied at 75, even though the math has completely changed. Think of it like this. Imagine you're driving an older car. It runs well. It gets you where you need to go. The engine has 250,000 miles on it, but it's reliable. It starts every morning. It's taken you everywhere you've needed to be for years. But now someone tells you they want to take apart the engine to check for a problem that statistically shows up in 1 out of every 100 engines like yours. Even if they find it, fixing it requires major work. Gaskets that have to be replaced, parts that might not be available anymore. And there's a real chance the car never runs the same after they put it back together. You might get it back and find it idles rough, or the acceleration isn't what it was. Or worse, it won't start at all. That's what we're doing when we order certain tests in patients over 70. We're looking for statistical possibilities, things that might be there, things that might cause problems someday. And when we find them, the system is built to intervene, not to wait, not to monitor carefully, to act, to fix. And that action, in an older body with less reserve and slower healing, often carries more risk than the thing we found ever would have caused. More than 60% of adults over 70 undergo at least one screening test each year that guidelines specifically recommend against for their age group. These aren't fringe procedures. These are tests ordered in standard medical offices across the country every single day. I want to walk you through 5 of them, not to make you distrust your doctor, but to make sure you ask the right questions before you say yes. Because once the test is done, once the result is in, the momentum toward intervention becomes almost impossible to stop. Let's start with the first one. Routine stress tests for heart disease screening in asymptomatic patients over 70. This one surprises people every time I bring it up. A stress test sounds harmless. You walk on a treadmill. They monitor your heart. What could possibly go wrong? Here's the problem. After 70, your heart has been beating for 7 decades. It's adapted. It's developed its own electrical patterns, its own rhythm quirks. Many of these patterns look abnormal on a stress test, even though they're causing you no symptoms and never will. The test finds something. The cardiologist orders more testing, an angiogram, a catheterization. Suddenly, you're being told you need a stent or bypass surgery. But here's what the data actually shows. In patients over 70 with no symptoms, no chest pain, no shortness of breath, no warning signs, aggressive intervention based on screening stress test results does not improve lifespan. It does, however, significantly increase the risk of procedural complications, bleeding, stroke, infection, kidney damage from contrast dye. I had a patient 2 years ago, 81 years old, played golf twice a week, no cardiac symptoms. His primary care doctor ordered a routine stress test. It came back abnormal. He was sent to a cardiologist. The cardiologist did a catheterization, found a 70% blockage in one artery, placed a stent. The stent caused a small dissection in the artery wall. That required emergency surgery. He survived, but he never played golf again. Would that blockage have caused him a heart attack? We'll never know. What we do know is the intervention itself caused the harm. Here's the question to ask your doctor. Do I have any symptoms that suggest my heart isn't getting enough blood? If I don't, what is the specific benefit of this test at my age, and what are the risks if it finds something? If your doctor can't give you a clear answer, that makes the benefit obviously outweigh the risk. You have every right to decline. The fix here isn't a procedure. It's a conversation. Write that down. Now, this next one is even more common, and it's one of the hardest to talk about because so many people believe it saves lives. Routine colonoscopy screening after age 75. Stay with me on this one. I know the first reaction. Colonoscopies detect colon cancer. Colon cancer is deadly. How could screening be harmful? Here's the mechanism. Colon cancer is a slow-growing cancer. From the time a polyp turns into cancer to the time it becomes life-threatening, typically takes 10 to 15 years. If you're 75 and you find early-stage colon cancer, you have an excellent chance of outliving it, even without aggressive treatment. You're statistically far more likely to die of something else first. But the colonoscopy itself carries real risk at that age. Perforation of the colon, bleeding that requires transfusion, complications from sedation, dehydration leading to acute kidney injury. And if a polyp is found and removed, there's the risk of post-polypectomy bleeding or infection. The United States Preventive Services Task Force, the group that sets national screening guidelines, explicitly recommends against routine colonoscopy screening after age 75 for people of average risk, not because they don't care about colon cancer, because the math doesn't work anymore. The chance of harm from the procedure starts to exceed the chance of benefit from finding cancer early. I've stood at operating tables repairing perforations in the colons of 78-year-old patients who had no symptoms and went in for a routine screening. One of those patients developed sepsis, spent 3 weeks in the ICU, never fully recovered her strength. The alternative isn't to ignore your colon health. The alternative is to switch to less invasive screening, annual stool-based testing. If that's positive, then consider colonoscopy. But routine scope after 75, especially if your last one was clear. The guidelines say no. Does your family history include colon cancer? Have you had polyps before? Have you noticed any blood in your stool or unexplained changes in bowel habits? If the answers are no, the benefit of another colonoscopy at 78 is marginal at best. The risk is not. 2 more items after this one, and item 4. That's the one that even I had a significant blind spot about for the first 15 years of my career. Stay with me. Let me ask you something before we go further. Have you ever had a test come back abnormal and felt relieved when they told you it was probably nothing? Most of us have. That relief comes with a cost we don't think about. The anxiety, the follow-up, the what-ifs. Now imagine that cycle playing out in your 70s and 80s, when your body's ability to tolerate interventions is already compromised. The third test is routine annual mammography screening after age 75, particularly in women with limited life expectancy due to other health conditions. Breast cancer screening saves lives. In younger women, the data is clear. But after 75, especially if you have other chronic conditions like heart disease, diabetes, or lung disease, the equation shifts. Mammograms find breast cancer, but they also find things that look like breast cancer. Suspicious spots, abnormal densities. Each one triggers a callback. A diagnostic mammogram, often a biopsy, sometimes surgery. The emotional toll of that process alone is significant. The physical toll can be even worse. Here's what amplifies the risk after 70. Recovery from breast biopsy or lumpectomy is slower. Wound healing is compromised. Anesthesia carries higher risk. And radiation therapy, if recommended, has side effects that hit harder when you're older. Fatigue, skin changes, potential impact on heart function if the tumor is on the left side. But here's the critical piece. Many breast cancers detected in women over 75 are slow-growing. Ductal carcinoma in situ, low-grade invasive cancers. These cancers may never progress to the point of causing symptoms in a woman's remaining lifespan. Yet once they're found, the system pushes toward treatment. I'm not saying ignore breast health. I'm saying the question to ask is different. If you're 78 and you have congestive heart failure and diabetes, and your mammogram finds a tiny spot of DCIS, are you better off treating it aggressively or monitoring it conservatively? The answer depends entirely on your overall health, not just the presence of cancer cells. I've watched families agonize over these decisions. A 79-year-old woman with a small breast cancer detected on routine screening. She underwent surgery, then radiation. The radiation weakened her already fragile heart. She developed arrhythmias, ended up with an implantable defibrillator, all to treat a cancer that her oncologist privately told the family would likely never have shortened her life. The conversation to have with your doctor. Given my other health conditions, what is my realistic life expectancy? If this mammogram finds something, how likely is it that treating it will actually extend my life versus just extend my time in treatment? That question matters. Starting tonight, before you schedule that next screening, ask it. Here's where it gets complicated. And here's the test I missed for years. Routine PSA screening for prostate cancer in men over 70. This is the one I used to recommend reflexively. Check the PSA. Catch cancer early. Seemed obvious. It's not. Prostate cancer is extraordinarily common in older men. Autopsy studies show that more than half of men over 70 have prostate cancer cells in their body. Most of those cancers will never cause a single symptom. They're slow growing. They stay localized. The man dies with prostate cancer, not from it. But the PSA test doesn't distinguish between aggressive cancer and indolent cancer. It just finds elevated levels. And once that level is elevated, the protocol is clear. Biopsy. If the biopsy is positive, the oncologist presents treatment options. Surgery, radiation, hormone therapy. Every one of those treatments carries life-altering side effects. Urinary incontinence, erectile dysfunction, bowel problems, fatigue. And in men over 70, the complications are worse and the recovery is slower. The United States Preventive Services Task Force recommends against PSA screening in men over 70. Not because prostate cancer isn't real, because in this age group, the harms of screening and subsequent treatment outweigh the benefits for the vast majority of men. I had a patient named Robert, 73, active, healthy. Routine PSA came back slightly elevated. Biopsy showed low-grade cancer. His urologist recommended surgery. Robert had the surgery. Developed severe incontinence. Required additional procedures to manage it. Never regained continence. Spent the last 8 years of his life wearing pads. The cancer? It was so slow growing that a follow-up pathology review suggested it likely would never have progressed. Would Robert have been better off never knowing? I think about that question often. The question to ask your doctor if PSA screening comes up. If this test finds cancer, what is the likelihood it's the kind that will actually threaten my life in my remaining years? And what are the side effects of treatment I need to be prepared for? If your doctor says most prostate cancers at your age are slow growing, and the side effects of treatment include permanent incontinence and sexual dysfunction, you have the information you need to make a choice. Not everyone will choose the same way, but at least you're choosing with your eyes open. One more. This is the test that even most doctors don't realize has flipped from helpful to harmful in the older population. Routine bone density screening. DEXA scans. In women over 85 with no history of fractures. Osteoporosis is real. Fractures in the elderly are serious. A hip fracture after 80 can be life-ending. So checking bone density makes sense, right? Here's the problem. After 85, almost everyone has osteoporosis by the technical definition. Bone density naturally declines. The DEXA scan will find it. And once it's documented, the prescription pad comes out. Bisphosphonates, drugs like alendronate, risdronate, zoledronic acid. These medications reduce fracture risk, but they also carry significant side effects. Severe bone, joint, and muscle pain, esophageal irritation and ulceration. Osteonecrosis of the jaw, a condition where the jawbone literally dies. Atypical femur fractures, where the thigh bone snaps with minimal trauma because the drug has made it too brittle. And here's the critical piece. If you're 85 and you've never had a fracture, your fracture risk is already lower than the population average. You've made it this far without breaking bones. Your lifestyle, your activity level, your muscle strength, these are protective factors that a DEXA scan doesn't measure. The intervention, prescribing bisphosphonates, assumes the scan result is more important than your actual fracture history. It's not. I've seen patients in their late 80s started on these drugs after a routine DEXA, who then develop such severe muscle pain, they stop walking. And what prevents fractures more than anything? Staying active. Maintaining muscle strength, not sitting still because your legs hurt too much to move. The better approach after 85, focus on fall prevention. Strength training, adequate calcium and vitamin D from food and sunlight. Weight-bearing activity. If you've never broken a bone, the drug may cause more harm than the osteoporosis ever would. Ask your doctor. I'm 86 and I've never had a fracture. What is my actual fracture risk compared to someone my age who has broken bones? And what are the side effects of the medication you're recommending? If the answer is that your fracture risk is low and the medication can cause jaw necrosis and severe pain, you might choose to skip the drug and double down on movement instead. That choice should be yours. I want to be honest with you for a moment. Not as a content creator, as a surgeon. I have stood at an operating table at 3 in the morning holding a heart that had been weakened not by disease, but by the cumulative burden of interventions that started with a single screening test. I have spoken to families in waiting rooms at dawn, families who had no idea anything was wrong when they said goodnight 12 hours earlier. In case after case, the contributing factors were not mysterious. They were routine tests ordered in the name of thoroughness, tests that found problems that might never have caused harm. And the treatments for those problems carried risks that were never fully explained. These are not exotic scenarios. They are the background noise of millions of ordinary doctors' visits, annual checkups, preventive care appointments, well-meaning recommendations. And that background noise, accumulated test after test, year after year, creates a medical cascade that leaves people weaker, not stronger. I want to tell you about a patient. I'll call her Helen. 76, retired librarian, fiercely independent. She came to me after a 2-year odyssey that started with a routine stress test her doctor ordered, just to be safe. The stress test was abnormal. That led to a catheterization. The catheterization found a moderate blockage, not critical, but present. The cardiologist recommended a stent. Helen agreed. The stent caused a complication. Emergency bypass surgery. The surgery was successful, but the recovery was brutal. 6 months later, she still hadn't regained her pre-surgery energy. She came to my office for a second opinion on another issue. I asked her to walk me through the timeline. She did. And then she looked at me and said, "I felt fine before all of this started. I still don't understand why we couldn't have just watched it." That question has stayed with me. It's a big part of why I make videos like this one. Helen is doing well now, 2 years later. She's reduced from 4 medications to 2. She's walking again. But she told me recently she wishes she'd known to ask one simple question before that first test. What happens if we don't do this? It is never too late to start asking that question. Let me recap the 5 tests we covered today. 1. Routine stress test for heart disease screening in asymptomatic patients over 70. If you have no symptoms, the test often does more harm than good. 2. Routine colonoscopy screening after 75 in average-risk individuals. The procedure carries real risk that starts to outweigh the benefit of early cancer detection. 3. Routine mammography screening after 75, especially in women with limited life expectancy. The anxiety and intervention cascade can cause more harm than the cancer would. 4. Routine PSA screening for prostate cancer in men over 70. Most cancers found are slow-growing, and the treatments carry life-altering side effects. 5. Routine DEXA scans in women over 85 with no fracture history. The medications prescribed often cause more problems than the osteoporosis. Which of these tests has your doctor recommended? Have you ever felt pressured to agree to a test you weren't sure you needed? Tell me in the comments. I read every single one. There is someone in your life, a parent, a spouse, a sibling, a friend, who needs exactly this information. Someone who's about to walk into a doctor's office and hear the words, "Let's just run a few tests to be safe." And send this to them. That one share might be the most important thing you do today. Every week I bring you honest, evidence-based information that I wish every one of my patients had access to long before they ended up in my office, facing decisions they never should have had to make. If you want more of that, subscribe. One last thing, and this is important. Everything I've shared today is based on published research and my clinical experience as a cardiothoracic surgeon. But your situation is unique. Your history is individual. Before declining any test your doctor recommends, please have a conversation with them. Ask the questions I've given you, but have the conversation. That conversation is not a formality. It is the whole point. Better information, better conversations, better outcomes. That's the chain that matters. Your heart has been working for you every single minute of every single day for 70 years, 80 years, without ever asking for anything in return. Before you subject it to tests and procedures it might not need, make sure you're doing it for the right reasons. Not because a box needs to be checked, but because the benefit is real and the risk is worth it. Take care of your heart.